Yeah, absolutely. I think we're doing kind of a similar thing. So thank you so much for having us here, Gov Connect. Met so many interesting people already today, interesting ideas. So my name's Nathan. By background, I've got a clinical background. I was a doctor for 8 years before I started an audit project that just has spiraled out of control, and then I've left clinical practice to do it full time. So I'm going to talk to you today about a case study, about a project we've done that was funded via the NHS Greener team and given to us via an SPRI Healthcare Award. So the platform that I've built and sort of lead transformation across the NHS is called CrossCover. It's essentially a workflow optimization system for clinical and non-clinical workflows. It's a UKCA marked medical device and can be applied to pretty much any specialty. So our mission really, what I started out, I think 6 years ago to do, was just to try and get our experts to work together and establish, well, what is best practice, and then similar-ish to what GERF does, but the bit I was really interested in is how do you actually get best practice applied? That massive cognitive dissonance between, you've got this huge amount of research and guidelines, and that's great, but how do you actually get people to follow it? So my experience, my first day as a surgical SHO in a North West London trust was during the Notting Hill Carnival, and I was put on cross-covering 4 surgical specialties and major trauma. And I thought, if this is what bigger doctors like, I'm going to quit, because I had a bleep going every 5 minutes for 12 hours, and I had 4 registrars that weren't necessarily very contactable I had to answer to. That lasted 1 weekend before someone realised that's a job of 4 people, not 1 person. But I felt at the time, I'd been through medical school, I thought I was okay, and I was just rapidly failing. I couldn't make decisions fast enough for this plethora of different complaints across so many specialties. And this is a problem I saw, that was a bit of an anomaly actually in hindsight, it got better. But I found repeatedly throughout my training, in my higher surgical training as an orthopaedic surgeon, was that you go through this process of osmosis as a clinician. You kind of just learn, like, oh, this is what you do in that scenario. There's people nodding in the room. You look back 6 years into your training and go, oh, back in my first year I saw this same thing. I just wish I'd done it slightly differently. So one of the problems I found, the challenge is that there's these massive bottlenecks in efficiency because a large proportion of the decisions made in the NHS are made by the non-experts. So, your junior doctors who necessarily are across many different things, but aren't experts in that subspecialty. So as I progressed to becoming a surgeon in theatre, I'd worked out in my head how to deal with the majority of orthopaedic presentations right through that process of osmosis. But then I was in a different problem. I was doing operations I hadn't done before, trying my best to do a good job for my patient while being interrupted by people asking the common questions. And I was like, look, this is literally an algorithm in my head. I'm going to go draw it down so people aren't waiting 2 hours in ED, waiting for me to finish an operation so I can go and tell people what should really happen. So massive variation in practice in the NHS, we all know that, and that can result in a lot of unnecessary appointments, investigations and treatments, which all have costs both in terms of finance and carbon. So our solution is a fully interoperable cloud-hosted force multiplier that allows you to, first of all, standardise your care, fully map out any decision support flow process for any presentation. It could be seen as a quality management system for clinical pathways, or a fully editable clinical textbook for your front line. So this next slide is going to scare you, but this slide is a decision support flow for ankle fractures, okay? So imagine sticking that on a poster and putting it on a wall somewhere. No one's going to follow it, right? So the posters that do go on the walls to cover everything are always too abstract, not detailed enough, and I am a little bit of a stickler for detail. If it's not detailed and granular, it's not going to be effective, it's not going to work. So this is how we build the pathways behind the scenes in the platform, but not how we show it to clinical staff. This is how we actually show it to them. So this is a pathway we built with Birmingham Solihull ICS to standardise their primary to secondary care workflows for MSK. This was part of the project funded by the Greener team, was just, look, there's 300 million general practice appointments a year, I think it's already mentioned today. About 20 to 30% are MSK related. Can we just get everyone doing the same thing, which is best practice, and then see what happens? So we went through all this learning journey over about a year, where we've got a specialist from multiple sites, consultants, GPs, physios, this awesome MDT in each subspecialty, looked at all the national guidance and built out the ideal flows for all these presentations. And we're currently deploying across Birmingham and Solihull 184 general practice sites to measure what's actually going to happen. So we've got a randomised control trial going on at the moment, and a health economic assessment looking at the financial and carbon impact. So this is a pathway essentially. You break down the decisions to its fundamental steps, record them as the clinicians follow it. We don't really assume there's any knowledge there, because there's going to be a normal curve of knowledge in any clinical flow. Then at the end, we try and help the primary care practitioners to give the patient sort of the same messaging, the same signposting, management and follow-up. So you reduce those health inequalities at sort of a scale that maybe hasn't quite happened before in terms of standardisation. This is an example of how we then standardise a whole service. So on the left-hand side, you'll see decision support flows from GP and ED. There'll be about 150 of those to cover all the different presentations. And then we'd link to ERS in primary care, so that when you have a referral from an endpoint that says you actually should consider a referral here to secondary care, you get a structured letter for that referral, and it goes via ERS and is captured at the other end and pooled with the non-ERS referrals as well. Then we went further and thought, well, actually, why not run your whole service from it, generate inpatient lists, managing, booking, all the rest of it. And so this is trying to fully virtualise that care journey and just get it as efficient as possible. And there are, luckily, from my perspective, so many opportunities to make innovative improvements to the overall clinical pathway. So what I've done is I've stepped out of clinical practice into engineering. And in engineering, building code and algorithms has been a very solved problem for a long time. Now, when you've got 5 or 6 people building the same algorithm or flow, you need a way to control that. So when in industry and engineering, you separate environments. You have a live environment and a development environment, and you have version control, and you have a change control process to go from development to live. So what we've done in the platform is we've abstracted this. There's no code in the platform. It's like a drag and drop. I think someone mentioned Lego system earlier. Might start using that, but I describe it quite a lot like a train set. We give you the train, the track, the train station, everything's connected, and you can sit with your clinical teams to be empowered to build any particular flow. So in other sort of platforms might take, someone wants to change, a box on a table to look at a different colour or a different status. They've got to ask their boss, email the company. A month later, it might come out as a change. In our platform, they can log in, change it in about 2 minutes, and go through a valid deployment cycle that will have notifications to the people on the approval policy to sign it off, then it goes live into the clinical flow, like literally 5 minutes later. So here's an example of how we make it so customizable. So I really feel that if you have a one-size-fits-nowhere national sort of algorithm, it doesn't work. It's so hard to operationalize. If you're really honest about it, they're quite often really good starting points. But this, for example, is Birmingham and Solihull's low back pain pathway, probably going to be one of the highest used pathways. Lower back pain is such a massive burden on the NHS, and we've crafted a really comprehensive pathway here that has about 280 possible routes through it, and there is zero chance that 2 clinicians in the whole city would think exactly the same way for all this stuff. But we've covered all the bases. And it's quite logical going through what are the emergency red flags, what are the urgent red flags, this is what they are they present or not? Is there inflammatory back pain? Is this musculoskeletal back pain? Explaining to them what you would look for, what variables you look for to make those decisions. So this is, you've probably seen something like, I don't know, those website builders like Wix and stuff. We've kind of made the platform a bit more like that, but with more guidance, more snap to grid, and we've got AI here that can write content for you. So if you, for example, wanted to ask a clinical question, or say you're a consultant, maxillofacial surgeon, you're writing a pathway for post-op instructions after wisdom tooth extraction, you could ask it, well, what are the post-op instructions? And it would generate the answer for you. But we know that AI confabulates. It's never 100% right. So this AI doesn't get presented to patients. It's presented to the experts so they can rapidly build guidance. They can validate it. And we found it kind of speeds up pathway development by about 60%. We've got loads of different widgetable components. We have thousands of medical illustrations just to bring the pathways to life. So when I said it's like a customizable interactive textbook, it kind of is that as well, right? So just trying to break down, think back when I was that junior doctor cross-covering all those specialties, this is what I wanted to have back then to help me make those decisions faster. Let's move on to the next one. So what's the sort of evidence of this? So before we were commissioned for BSOL, they wanted to do a service evaluation looking at, well, what actually is the problem and status quo? So lots of you will have heard of OSCEs, Objective Structured Clinical Examinations, how you examine doctors, do they know what they're doing? What we did for this was we got 8 sort of clinical scenarios: back pain, shoulder pain, knee pain, hip pain, 2 variations for each, and got 20 GPs to see a patient normally or with a pathway, and they were randomized to one intervention first or the other. And so it was 152 scenarios, the same patient seen by 20 different people, and usual care took 11 minutes 40 seconds from the patient entering the GP's room to leaving. But with a pathway, it was reduced by about 30%, and they had no training on how to use the system. And when it comes to like an OSCE, you have a scenario created for the actor by the experts in the exam setting. You have an expected set of, this is the ideal response. So the primary care physicians got the ideal response just under a third of the time. That doesn't mean they got the wrong response. It means that they may have ordered an extra X-ray or some blood tests that weren't needed that have a financial and a carbon cost, and potentially slow down the patient getting to where they eventually need to get to. So we were able to show that we could reduce the unnecessary appointments significantly and the unnecessary investigation significantly. So what I found as a clinician going into the side trying to get change from outside the NHS is, number one, a system has to be clinically effective. It's got to work, right? Number two, I found it's got to be cost effective, or no manager's going to pay for it or use it, right? So then you've got number three, close third for me, is it carbon effective? So we actually had NHS England funded with a different SPRI award we had, looking at the budget impacts analysis of optimised pathways versus usual care, and it saves about £100 per patient. So I'll tell you why that's the case. So if you have a patient with a stable ankle fracture in ED, to work out it's stable, there's a few things you have to do. And for some scenarios, what will happen is you've actually got a stable ankle fracture, but the patient's put non-weight bearing in a plaster, given venous thromboembolism drugs and 2 crutches, and brought back to fracture clinic in 2 weeks. When they're back in clinic, lots of the staff will just wrap it in more plaster, bring them back in 6 weeks, right? Whereas what you probably should do in those scenarios, there's a specific scenario, it's quite common, is you do a weight-bearing X-ray in ED, and if it's stable, you can put them into a walking boot and actually discharge them with PIFU. So for that one patient, you save £900, 2 appointments, 2 plaster changes, VTE for 6 weeks, all the rest of it. So on average, it's about £100 saving. So what we've done so far, this is a bit out of date actually, we're about 50 sites now. We optimise the care for probably about 1,200 patients a day at the moment. Over 600,000 care miles saved. And as we deploy across all these general practices, it's another learning journey for us. It's just trying to win those hearts and minds of those clinicians. It's just, it's a new way of working. So yeah, one of our biggest changes is actually reducing clinics. So this is fracture clinic follow-up by 50 to 80%. So a huge amount, especially in the hand service down in Cornwall, there were a lot of patients referred to fracture clinic that potentially could be discharged with PIFU. We've managed to reduce that substantially. So the RCT going on at the moment, that service evaluation I just showed you, that was the beginning to go actually do an RCT on this. It's a step wedge randomised or cluster trial looking for non-inferiority as we activate clusters of general practices across Birmingham, comparing what is status quo versus intervention, and there's lots of KPIs. And Professor Hill and his team at Keele University that are just simply awesome at investigating primary care MSK pathways are leading that study. We're supported by YHEC, who are great, who are doing carbon and financial impacts models off these as well, just to see what is the actual cost saving. Does it save money? Does it save carbon? Does it result in non-inferior treatment for our patients? Now, unfortunately, it's only a 3-month follow-up. You probably need to follow up MSK stuff for 12, 15 years. And even then, the best RCTs in orthopedics, people will argue over them when they don't show the results they want. Socioeconomic effects. So you know all about this already. I'm not going to reiterate this, but massive numbers of unnecessary care miles from unnecessary appointments and investigations. And we think we can reduce it by about 90% by just getting the right decisions made. Not the first time, but every time. Addressing health inequalities, so probably the thing I'm most proud of actually is, wherever you go in the NHS, you deserve to get the same treatment. And you can only get the same treatment if people are doing the same thing. right? So I found when I was a clinician, I felt my job was kind of three things. It was, one was working out what is the diagnosis of this patient. Another one was actually treating them. The third one was actually looking after them as a human being. And I think quite a lot of the time, staff get so focused on what do I actually have to do, I'm so overwhelmed, you can almost fall a bit by the wayside in that the softer skills that something like AI and will never replace. I've heard a lot of stuff today about data. So as a software company, we measure huge amounts of data points on every interaction along these care pathways. So this is a Sankey chart showing, I think, for metacarpal fractures in Cornwall, every decision point in those decision support flows is measured and anonymously pull the number of patients through every flow. So what I get asked by ICSs is, help us with our workforce planning for the next 10 years. And I go, okay, what do you currently do? And like, whatever they say, the current flows aren't right. So you have to start off by going, this is what we should be doing, deploy it for 12 months, measure how many patients go down every branch. Then you can say, well, in a year, about 21% of your patients with this presentation are going to need an MRI scan. With who actually do need one, therefore we need this many MRI scanners, this many facilities, this many radiographers. So it's kind of workforce planning intelligently based on data from the actual correct processes being deployed. So what have I learned from trying really hard to make a change in the NHS? Winning hearts and minds is the most important thing, especially with the green agenda, is that you've got everyone's work lists are on fire, they have staff on strike, and you come to them talking about trying to save carbon, and they're like, that's like not even on my top 50 list, right? So it's really important to just, you can't have solutions that just kind of do one thing. I think to get them actually in the front door, you've got to be multifactorial, you've got to be clinically effective, you've got to be financially cost effective, and they're not mutually exclusive. A more clinically effective solution is often financially more effective and carbon more effective. So this is one I found outside of the NHS when I stepped out. So I was used to being a registrar and the consultants with so much, authority. The minute I stepped out, I realised, wow, the clinical directors are asking me, how do I do X, right? And it seems to be on a Saturday morning for some reason. People wake up on Saturday morning going, Nathan, help, I need to change the whole service. I'm like, okay, this is what we're going to have to do. It's going to take 6 months before you even get in the front door. You have to talk to all these people. So I've written the business plan for you. It will help you get through that. Will help you win all those little battles. But you've got to support your NHS champions, just because once they decide they want to, do massive QI project, change the whole service with us, we're super keen to do it. But it takes a lot of effort from them. No matter what happens, like the NHS is an immovable object sometimes. We've had to be extremely agile. We are a very agile company. Like the platform we've built, it's designed for iterative improvement of pathways all the time, not a waterfall build and then stop. And as a company, we constantly listen to our customers, and we do what's called 2 weekly sprint cycles. So we'll plan all our work and engineering just for 2 weeks. Then if we have requests from NHS staff going, I want this change or that in, we can pivot very quickly. Have a plan B. Life happens to everyone in project teams. You've got to have resilience and depth there. And I found what's really important to get anything changed is that top-down and bottom-up approach. So from my perspective, getting clinicians to understand the solution is really easy. Then I go to managers and explain the economics behind it, and that is relatively easy at times. But the top-down, trying to explain, the executive level what's going on, it's variable. Some are really awesome, they just get it straight away. But, understanding the clinical problem can be a bit abstracted for the managers that haven't necessarily... Sorry. Okay, no worries, it's the last one. So in summary, essentially trying to improve clinical effectiveness, improve efficiency, optimise outcomes through sustainable models of care. So we're happy to work with anyone that wants to just make massive change happen. If you want to just talk about change management and quality improvement projects, just give me a call or email me. But thank you very much.
Thank you. That was a really great talk.